And in that case, you can see that if we consider one single proton beam with a certain enlargement of the Bragg peak, it can be used very easily. And this was the technique which was really introduced more than 30 years ago, and we have experience with several thousands of patients with that. You can see here the tumor and the procedures. There are tanta tips which should be sewed only for positioning and for position control during the treatment delivery. And you can see the tanta tips here on the CT and the planning process at the Nice cyclotron, where 65 MeV protons are used with a fixed beam. And the Bragg peak could be enlarged with a modulating propeller, with modulators, and the wax bolus and cerebral aperture can be made to individualize the treatment, and different calculation algorithms are used. The ray tracing, those algorithms, this is the most simple one, fast but not provide enough accuracy. The pencil beam algorithm is used recently, used worldwide, and recently the Monte Carlo those calculation algorithms were tailored for that purpose, eye proton therapy, which reduced the calculation time and which result calculation of the dose distribution of the eye. It can be modified as well as with wedges, and the patient is looking on this small diode. The eye is enlarged in a video in a TV with a camera, and 0.1 millimeter movement stops the beam automatically. You can see the position and fixation of the patient. She has even a bile block. And this was prior to the treatment. This is after 1 month, and later on the tumor has been completely diminished with a little brown place of beam entrance. And a part of that, there are a lot of tumors which can be treated, especially with very advanced facilities where the gantry can be turned, but I would say not the gantry, but the whole room is turning around the patient. Yes, because this is the gantry, and it is turning. Of course, here is the gantry exactly, and the whole, some tons of walls are moving together, like in London Park. And the centers number are growing both in Europe and in Asia and in America. And the carbon ion therapy centers as well as treated already more than 10,000 patients. And at the end of this talk, I have summarized some clinical results, because it's always a huge question, because this technique is extremely expensive, both the construction and the maintenance. Is there any sense to use that, especially in the scope of the possible techniques which are available for advanced photon and electron radiation technique? Is there any sense to construct and maintain and perform therapy with protons and hadrons? And there are growing evidence of benefit from protons, so it is important to prove always the evidence at a clinical research level. And the early research shown only the calculation of difference. This is calculated proton therapy absorb really the dose where it should be, and the IMRT, the best photon therapy, has a larger part which absorb those, and the CNS tumors has the same thing. There are growing benefit for chordoma and chondrosarcoma patients, neuroblastoma patients in the head and neck region, it is evident if someone looks on the X-ray IMRT, the best technique which is achievable with photons. It gives a large integral dose, low dose, but in a large volume. And in comparison, the proton technique as well as improves. There is a possibility to intensity modulated proton application, a possibility of raster scanning proton application, which gives even improved dose distribution. This has very important, very high importance because this tumor, this medulloblastoma, which requires the irradiation of the complete brain and spinal cord, the craniospinal axis, is done with a special technique, but nevertheless here in the midline there is a relevant dose absorbed if the best photon therapy applied, and with proton therapy really it could be tailored and homogenized only where it is necessary, and you can see the comparison of it. So head and neck tumors, paranasal sinus tumors, lung cancer patient can profit from this technique. You can see it is very visible already from the first view that much better dose distribution could be achieved. The esophageal tumor can be irradiated only with a lot of, because it is in the middle of the body with lot of beams to achieve this dose distribution with the best photon technique. Meanwhile, with two beams, the spinal cord can be spared properly, the heart can be spared properly, and the tumor could be covered as well as properly. Breast cancer, both the small volume irradiation, the partial breast irradiation, or the whole chest wall irradiation can be, you can see as well as a much nicer dose distribution over there. So finally, soft tissue sarcoma and proton, finally we can summarize that all of the locally growing tumors surrounded by radiosensitive tissues can profit from hadron therapy. And we will think about after the break and after the lecture of Bettina about the molecular processes, why it has not spread in spite of this lack of benefit to each hospital. Why do not have the proton beam? So thank you for the attention for this part. Nobody. I think that it was quite immense for everybody. You can ask if you want, but I think that we have a little refreshment and I'm available there. So if someone would like to ask something, I can answer on that.